Hi everyone, it's Malik here. In this video we're going to go through a carpal tunnel release. We're going to first of all cover the anatomy, then the setup and preparation, the anaesthetic technique, prepping and draping, and then the procedure itself. We'll end by going through a few tips and tricks to keep us out of trouble. There are many anaesthetic techniques which we will briefly discuss later, but one of the most straightforward and commonly used methods is a local anaesthetic infiltration, so we're going to cover that here. Now, to be able to put the anaesthetic in the right place, we need to know where our incision is going to be and why. So let's start by going through the relevant anatomy. The floor of the carpal tunnel is formed by the carpal bones. The roof is the transverse carpal ligament, which has 4 points of attachment onto the carpal bones. On the radial side, it's the scaphoid tubercle and the trapezium, and on the ulnar side, the pisiform and the hook of the hamate. Arising from the transverse carpal ligament are two main muscle groups, the thenar and hypothenar muscles. There's also one more muscle to add in, palmaris brevis. This runs from the transverse carpal ligament and palmar aponeurosis to the skin on the ulnar border of the hand. It's a muscle you'll often see during your approach. While we're here, let's go over the difference between the transverse carpal ligament and the flexor retinaculum. They're often used interchangeably and that can be confusing. The transverse carpal ligament we can see here with our 4 attachments as described. The flexor retinaculum, however, is a larger structure which actually incorporates the transverse carpal ligament. It has 3 main parts. The distal portion is an aponeurosis between the thenar and the hypothenar muscles. The thick central portion is the bit that we're interested in for our carpal tunnel release and is the transverse carpal ligament. The proximal part of the flexor retinaculum is continuous with the deep investing fascia of the forearm. Now that we've defined the tunnel, let's look at what goes through it. It contains the 4 tendons of flexor digitorum profundus, the 4 tendons of the flexor digitorum superficialis, and the tendon of the flexor pollicis longus, and of course, the median nerve. There are a few other structures around here, so to hopefully avoid any future confusion, let's put them in so that we know where they are. The first one we'll add is the flexor carpi radialis. Now this actually runs between superficial and deep layers of the transverse carpal ligament, sitting in this oblique groove of the trapezium, and therefore does not pass through the carpal tunnel. Neither does the flexor carpi ulnaris, which inserts into the pisiform proximal and superficial to the carpal tunnel. The last tendon we'll look at is palmaris longus. This inserts onto the central part of the transverse carpal ligament and becomes continuous with the palmar aponeurosis. The tendon is absent in about 15% of Caucasians, but this can vary with other races. It's also worth mentioning that it can be confused with the median nerve, especially if palmaris longus is absent. The median nerve is the real reason we're here, so let's look at that for a bit. It sits slightly radial in the carpal tunnel and gives off 2 branches that we need to know about. The palmocutaneous branch, which supplies sensation to the skin at the base of the thenar eminence, and the recurrent motor branch, which innervates the thenar muscle. The palmocutaneous branch arises from the radial border of the median nerve, then runs between palmaris longus and FCR until it passes superficial to the transverse carpal ligament and runs along the thenar crease. The recurrent motor branch supplies the muscles of the thenar eminence and arises from the median nerve distal to the transverse carpal ligament, though many variations have been described. Despite this, it's important to remember that both of these structures generally run radial to the median nerve, which is important when planning our incision. For completeness, let's add the radial artery and the ulnar artery and nerve. Both arteries branch and join to form the superficial and deep palmar arches. The ulnar artery runs with the nerve in Guyon's canal before branching. The radial artery splits, with the superficial branch running through the thenar muscles and the deep branch running around the anatomical snuff box. Now we know where everything is, let's plan our incision. Let's draw a line running along the radial border of the ring finger, or alternatively, if you flex the patient's ring finger, in line with that, our incision will be along this line. The limits of our incision will be defined by 2 lines, the distal wrist flexion crease and Kaplan's cardinal line. The distal wrist flexion crease marks the proximal border of the transverse carpal ligament. There have been many described variations of Kaplan's line, including by Kaplan himself, to identify the location of different structures in the hand, such as the superficial palmar arch or the motor branch of the median nerve, and that can be quite confusing. In this procedure, we're most concerned about the superficial palmar arch. So we'll draw it as a line running from the ulnar border of the extended thumb to the hook of the hamate, roughly parallel to the proximal palmar crease. This should be the distal limit of our incision, so if we stay proximal to that, we can avoid damaging the superficial palmar arch. It's worth mentioning that even though the deep palmar arch looks closer to our incision, because it is deep to most of the structures of the hand, it's actually not at risk during this procedure. You'll notice that the incision is a few millimeters ulnar to the thenar crease. If our incision is too radial, such as in the crease itself, we risk damaging mainly the palmocutaneous branch of the median nerve, and to a lesser extent the recurrent motor branch distally. It also puts any scarring directly on top of the median nerve, which we want to avoid. If our incision is too ulnar, we may end up in Guyon's canal, risking injury to the ulnar artery and nerve. Great, so now we know where our incision will be and why. Let's move on to the next step. You can use the time it takes for the patient to get to theatre by drawing up your local anaesthetic and making sure you have the right equipment for the case. You'll need a tourniquet, and some people recommend using a forearm tourniquet in obese patients. You'll need an arm board, you'll need your local anaesthetic, and if you don't have an assistant and would like to use one, you'll need to ask for a lead hand. Loops are used variably according to preference. You may be more likely to spot variations in anatomy, such as a crossing cutaneous branch of the ulnar nerve in the distal part of the wound, which is present in about 15% of people if you do use loops, but again it's down to preference. Where you sit is another personal preference thing. You can sit in the axilla, on the outside, or even at the end of the arm board. There will be a bit of leaning either way to make sure you can see down the incision proximally and distally to make sure the ligament has been released, but again, where you sit is up to you. Here, we're going to sit in the axilla for doing both the left and the right side. If you're doing this under local anaesthetic, you don't really need to bother with the anaesthetic room and can generally get the patient straight into theatre. So the most efficient way to get started is probably to get the patient to climb onto the operating table themselves if they can, do your WHO and all your other preoperative checks, put your local in, and then go get scrubbed while it starts kicking in. As I mentioned before, there are other anaesthetic options such as general anaesthetic, Beer's block, auxiliary blocks, and so on, but most surgeons tend to do this under local because it's fast and you don't need an anaesthetist, but the downside is that you have a bit less time to do the procedure, both due to the limited duration of the anaesthetic block and also due to the fact that the patient may not be able to tolerate the tourniquet for very long. We're going to use a combination of long and short-acting anaesthetic, and we'll use 5 ml of 1% lignocaine and 5 ml of 0.5% levobupivacaine. If you have the time, facilities, or inclination, you can reduce the sting of the anaesthetic by warming the lignocaine to 37 degrees or by adding bicarbonate to buffer the acidity. The final option worth mentioning is the combination of a local anaesthetic such as lignocaine or xylocaine with adrenaline, where the vasoconstriction caused by the adrenaline increases the length of duration of the anaesthetic, but also stops any bleeding so you don't have to use a tourniquet. Prep the skin, check your local again, and then you're ready to go. You're going to first infiltrate the carpal tunnel itself, then come back and raise a skin bleb, then infiltrate along the incision inside. Start with your needle in line with your incision at the distal wrist crease. Aiming about 45 degrees dorsal and distal, insert the needle until you feel the resistance of the transverse carpal ligament. If you push a little harder, you'll feel a pop as you overcome the resistance and enter the carpal tunnel. Aspirate, then inject the first few mils. There shouldn't be any resistance as you do this, and the patient will often feel tingling in the sensory distribution of the median nerve if you're in the right place. Keep injecting as you withdraw the needle until you get to the surface of the skin, then raise a small bleb. Reinsert the needle in line with your incision, moving distally, aspirating as you go, and you can see the skin blanching here as we inject. With your last mil or two, infiltrate proximally to make sure that the whole of your incision is fully anaesthetized. We can see that pop as we go through the transverse carpal ligament again quite nicely here. Sometimes when you enter the carpal tunnel with your needle and start injecting, the patient will feel a sharp sting. This means that you're a bit too close to the median nerve, so just withdraw slightly and you should be able to infiltrate again without any problems. This part is relatively straightforward. After you or the theatre staff have put on a tourniquet and you're scrubbed, start to prep the hand. If the patient's awake, they can hold their arm up for you, otherwise an assistant can give you a hand. You'll need 2 sponge holders, generally one used to support the hand and the other to do the painting. If you start with the palm facing up, prep the palm and volar forearm before asking the patient to flip over to paint the dorsum of the hand and forearm. Your drape will be placed around the proximal forearm, so make sure to prep up to the elbow. Finally, make sure you prep well in the web spaces and on the fingertips around the fingernails, and don't forget the ulnar border of the hand and forearm. It doesn't really matter what order you do this all in, as long as you're systematic. Throw out your swabs, and whilst keeping the patient's arm up, put a sterile drape on the arm board. If you have a fenestrated drape like this, grab the hand through the hole and put the drape over the patient. Remember that they may be awake, so just be a bit careful when putting it over their face, as you don't want to smother them with it. Get your lights in position and double check that you're operating on the right side. Start by exsanguinating the hand. A crepe bandage wrapped tightly around the hand and forearm, starting at the fingertips and moving proximally will do the job. And once you've done that, inflate the tourniquet to 250 mm of mercury and then remove the bandage. Your block should have worked by now, so check the anaesthesia before you start by pinching the skin over your proposed incision with some toothed forceps. Remember, the patients can often feel movement or pressure, but shouldn't feel any pain. If that's fine, then you're good to go. Remember the landmarks for your incision, in line with the radial border of the ring finger, from the distal wrist crease to Kaplan's line, and avoiding the temptation to put the incision in the thenar crease. You're going to use a 15 blade for the whole procedure. After you complete your skin incision, use dissecting scissors to dissect through the subcutaneous fat. Remember, there may be a crossing sensory branch of the ulnar nerve distally, and the blunt dissection will help avoid injury. One of your best friends for this procedure is your West self-retainer. Inserting it now will help your dissection, and you can now visualize the palmar fascia, a thick fibrous layer of tissue. You can differentiate it from the transverse carpal ligament by the direction of its fibers. The palmar aponeurosis has longitudinal, slightly divergent bands compared to the transverse carpal ligament's transverse bands. If we look at it close up, we can see the longitudinal fibers of the palmar aponeurosis here on the left and compare them to the transverse fibers of the transverse carpal ligament on the right. You can use blunt dissection to go through this, but it's probably easier to incise it using your scalpel in line with your skin incision. Once through the palmar fascia, you've reached the transverse carpal ligament. Here we can see some muscle fibers overlying it, which are from our palmaris brevis muscle that we mentioned earlier. Let's resite the West retractor, putting the teeth underneath the layer that we've just divided to improve our field of view. The muscle fibers are in our way, so we're going to get rid of them by bluntly scraping them off the transverse carpal ligament using our forceps or a swab. Our assistant here has put the flat end of a Sen retractor into the wound to give us a slightly better view. The transverse carpal ligament is seen here fully exposed, with the transverse fibers visible as we saw before. Now we're ready to incise the transverse carpal ligament, again in line with our skin incision. We're going to start by making a small incision in the ligament using the blade. Do this gently and carefully to avoid damaging the structures underneath. It has to be long enough to be able to admit a McDonald's elevator. Get your McDonald and, using the curved end, insert it through the opening you've created with the curved tip pointing up. This will help protect the median nerve as you divide the transverse carpal ligament. It isn't foolproof, however, so don't rely on it completely. Careful surgical technique and vigilance is still required to avoid injury to the nerve. Then take your scalpel and turn it so that the blade is pointing upwards. Put the tip of the blade on the McDonald and then divide the ligament by sliding the scalpel proximally along the surface of the McDonald's elevator. Repeat this process to divide the ligament distally. You do have 1 centimetre or so before you get to the superficial palmar arch, but to be safe you don't want to go much further than the limit of your skin incision. To avoid the blade from slipping off the McDonald, feel for the curve at the end to know that you're approaching the tip, or advance the McDonald with your knife. Alternatively, you can use your dissecting scissors to divide the ligament under direct vision instead of the blade, but you still should use your McDonald to protect the nerve and tendons underneath. The ligament is quite thick, and often as you divide it completely, you feel a give, which you can see here. We don't always get this tactile feedback, and often we can't see the limits proximally and distally of the ligament to be able to confirm visually that it has been fully released. One of the commonest reasons for failure of this procedure is incomplete release proximally, where the flexor retinaculum becomes the antebrachial fascia. So we need to make sure that we've completely divided the ligament before closing. You might find that resighting your West retractor a little bit deeper improves your vision, but also puts the ligament under a bit of tension, making it easier to cut, or at the very least feel if it's still in continuity. It's important that you don't put the retractor into the carpal tunnel itself, so make sure that the teeth are superficial to the transverse carpal ligament to avoid any injury to the contents of the carpal tunnel. To check your release, insert the curved end of your McDonald under the ligament proximally and lift up, effectively trying to hook the tip around the proximal border of the ligament. Try to pull it back out gently. If the ligament is divided completely, it'll slide out without any resistance, but if not, you'll feel the lip of the remaining ligament, so use your scissors or blade as before to divide it completely, before checking again, and then checking your distal release. Once that's done, inspect the nerve, and then you can go ahead and start closing. We'll close the wound using a 3/0 nylon suture, though 4/0 is also commonly used. It's a single layer skin closure using interrupted horizontal or vertical mattress sutures to avoid inversion of the skin edges. Once you've finished suturing, cover the wound with a paraffin gauze, then a folded dressing gauze, and sterile wool and crepe, keeping the wrist in neutral and taking care not to impede finger movement by keeping the bandage proximal to the MCP joint. Naturally, if you have a preferred dressing type or technique, you can use that instead. Lower the tourniquet, ensure limb elevation, and you're done. This is a relatively straightforward operation, but there are a few tips to help you avoid difficulty. Some of them we've already touched on, but it's probably worth going into them in a bit more detail. The first thing worth mentioning is that the hand has a tendency to pronate, which can throw you off course without you realizing. It's quite difficult to spot, but in this video you'll notice it when the surgeon pushes the hand back to lie flat against the armboard. A little bit later on, he's keeping the hand supinated with his index finger, but when he takes his hand off, the same thing happens each time. Why is this an issue? Well, what we're trying to achieve is to travel vertically down into the carpal tunnel from our initial incision. With the hand pronating, you can very easily drift ulnarly and end up near the ulnar nerve and artery. What will usually happen is that when you start dividing the transverse carpal ligament proximally, you'll actually be entering Guyon's canal. To avoid this, first of all, be aware of it, and then use an assistant, such as your scrub nurse, to hold the hand supinated, or use a lead hand, as you can see here, where it's holding the hand supinated and the digits extended, with a swab under the MCP joints dorsally to provide some cushioning. Following on from this, the amount of muscle that you come across during your approach can be a warning sign of drifting too ulnar or radial. These pictures all show different amounts of normal palmaris brevis encountered after dividing the fascia. Top left is obviously the bulkiest, and top right has no muscle at all. Sometimes the muscle can be obscured by fat proximally, as we can see in the bottom left image. If you do come across a lot of muscle tissue, you may have drifted into the thenar or hypothenar muscles, being too radial or too ulnar in your positioning. It can be normal, such as the picture in the top left, but it's worth just taking a second to reassess your position. The last point worth mentioning is your own positioning. I mentioned at the start that some surgeons sit at the end of the armboard looking along the axis of the arm, but if you do choose to sit on the side of the armboard as we are here, it does help to lean or move around a bit and look down your incision, because you can often see the ligament a bit better and divide it under direct vision, as you can see here. You should still check with the McDonald, as we demonstrated earlier, but it can make things easier. Okay, that's us done. I hope it was useful, and we'll see you next time.